Cell injury 4. Rest of morphological changes of necrosis. By the end of this lecture, you should be able to list types of necrosis, explain the causes of morphological changes in different types, and describe these morphological changes and list examples for different types of necrosis. Remember that we already explained two types of necrosis, coagulative type of necrosis, and we just remember that by the shape of the tissue is totally liquefied with loss of all cellular details. Then we have the caseous necrosis, and this is our issue today. The caseous necrosis looks like cheese, and we have two with F, fibrinoid necrosis, and fat necrosis, and lastly we have the gangrene. Caseous necrosis. Caseous necrosis is a distinctive form of necrosis that is common in foci of tuberculous infection. You know TB, tuberculous infection، اللي هو ايه؟ اللي هو الضرن أو السل. يبقى الضرن أو السل اللي هو tuberculosis بيحصل فيه نوع من النكروزيس اسمه infection. It is a combination of coagulative and liquefactive necrosis leading to formation of a semiliquified necrotic tissue. يبقى هو خليط من الكواجولاتيف على الليكوفاكتيف necrosis ويطلع النكروتيك tissue semiliquified عامل زي الجبنة الطرية. It is cheesy like cheese, so it is a combination of coagulation and liquefaction, so leading to semiliquified necrotic tissue that looks like cheese. The term caseous is derived from the cheesy white gross appearance of the central necrotic area. So the cheesy white appearance of this central necrotic area brought the term caseous. And it is derived from the protein casein. Casein is a milk protein. So this is the derivation of the term caseous. Cheesy white gross appearance of the central necrotic area, it looks like cheese, and they called it after casein, which is a milk protein. What is the mechanism of caseous necrosis? Actually, it is related to type 4 delayed hypersensitivity reaction. When you take the hypersensitivity reactions in immunology, you know that there are 4 types of hypersensitivity reactions. The type 4 one is related to cell-mediated immunology, and cell-mediated immune mechanism result in formation of a collection of modified macrophages that is called granuloma. So in type 4 delayed hypersensitivity reaction, which is cell-mediated immune response, is associated with the activation of helper T cells that stimulate the a collection of modified macrophages to the area of necrosis, and these are called the granuloma. So we have a collection of histiocytes that are modified to give a certain picture. You are going to take that whole picture of granuloma later on in the chapter of granuloma, but now we know that the caseous necrosis occurs in the setting of granulomatous reaction, which is type 4 delayed hypersensitivity reaction. There is a release of lipids from the walls of mycobacteria, which is Mycobacterium tubercle bacilli. They have a lipid coat and protein core. This lipid coat shows a lot of lipids. These lipids are released within the granuloma, leading to by immune destruction by activated macrophages, lead to the cheesy appearance of the necrotic tissue. So necrosis occurs due to delayed type 4 hypersensitivity reaction that forms a granuloma, which is a collection of modified macrophages. There is a release of lipids from the walls of mycobacteria after immune destruction by the activated macrophages, and this lipid release leads to the formation of this cheesy material. This is responsible for the appearance of this cheesy material. If you look at the gross picture of lymph node tuberculosis, this is a group of mesenteric lymph nodes. This is mesentery with group of mesenteric lymph nodes. These are the mesenteric lymph nodes. These mesenteric lymph nodes are enlarged. The cut section of them shows what? Shows loss of the lymphoid structure and replacement by this cheesy yellowish white material that looks like cheese. So there is destruction of the lymphoid structure and the tissue is replaced by this cheesy yellowish white material, necrotic tissue, which is called caseous material. So this is the caseous material or caseous necrosis. Again, we can see here a lung. This is a lung, and this lung shows here a cavity, and this cavity is filled with cheesy caseous material. Here is a lymph node with tuberculous caseous necrosis, and here again there is mesentery, and all these mesenteric lymph nodes are enlarged and they are adherent together, matted together, and the cut section of which shows destruction of the lymphoid tissue and replacement by this cheesy yellowish material. So this is the caseous necrosis with cheesy yellowish material that is pasty like. It is paste, looks like paste, زي المعجون, pasty or looks like paste, and it is semi-liquefied. It is not hard and it is not totally liquefied. Microscopic picture, we have said that the responsible mechanism for development of caseous necrosis is type 4 delayed hypersensitivity reaction with formation of granuloma. And so we have always collection of histiocytes like that. This is a lymph node, and you have these collections that are pale eosinophilic in color, and these collections are actually collections of histiocytes, modified histiocytes, and this collection is called granuloma. You may have some giant cells like that with multiple nuclei. This is a giant cell, and you have these cells like that. These cells contain a lot of lipids, and so they have foamy cytoplasm, and sometimes you cannot see their cell membranes. Okay, so they form a single mass like that, okay, containing the cells. And when they acquire this picture, they call them epithelioid cells. We are going to take this in details later on. Epithelioid cells. Fine. Beside the presence of these granulomas, you find something amorphous here. Amorphous, it has no structure, structureless. You don't have any structure here. Something that is eosinophilic, and it is granular, and it doesn't have a certain structure. If you look at this picture, again you have these are the granulomas, and these are the histiocytes, modified histiocytes. They lost their outer membrane, is not apparent, as if they are one mass like that. And in the center here of these granuloma, you can find an area of granular amorphous eosinophilic material. This is the area of caseous necrosis or caseation. So microscopically, the necrotic focus is composed of structureless amorphous granular debris enclosed within distinctive ring of granulomatous inflammation, and the tissue architecture is completely obliterated. You have loss of the normal architecture and replacement by this granuloma and caseous necrosis that destroys the underlying tissue, and you don't find the outlines preserved as in case of coagulative necrosis. So it shares the loss of architecture with the liquefactive necrosis. Okay, so this is the microscopic picture of caseous necrosis. Match question: liquefactive necrosis, caseous necrosis, coagulative necrosis. Okay, in B, cheesy, partially liquefied necrotic tissue goes with what? Okay, cheesy and partially liquefied, so this is the caseous necrosis. Preservation of the cell's structural outlines, this is present only where? In coagulative type of necrosis. as we have said before and we have seen before, the renal tubules, they show ghosts of renal tubules. Amoebic liver abscess is an example of yes, liquefactive type of necrosis, may be mistaken for cancer breast. Nothing of this, we haven't taken this yet. Fourth type of necrosis has F. We have two types of necrosis, starts with F, fibrinoid and fat. The fibrinoid necrosis is a distinctive form of necrosis called fibrinoid. It is fibrin-like. So it is seen in immune reactions involving blood vessels and sometimes in cases of very high blood pressure called malignant hypertension. You are going to take this later in cardiovascular system, malignant hypertension. Okay? So in immune reactions involving blood vessels and in malignant hypertension, I have destruction of the wall of the blood vessel, and I have the entima here is destroyed or it is injured, and then I have some proteins present in the lumen here in the blood. These proteins will go into the destroyed area in the muscle here due to high pressure or immune reaction, and it will be filled with this proteinaceous material that looks like fibrin. This protein looks glossy, eosinophilic, okay, and the wall of the blood vessel here is weakened because you lost part of the wall, and it is replaced by something that is more or less liquid-like, proteinaceous, okay, and this replaces the media, and so the vessel wall becomes weakened. Okay, so here, if you look here, you have the lumen of the blood vessel in here with these RBCs. Here is the endothelial lining. Here we can find the area of the media is replaced by this amorphous pink refractile necrotic tissue, which is the fibrin-like protein material, fibrin, immunoglobulins, plasma proteins. They are deposited here in the affected wall, leading to bright pink and amorphous appearance. In the rest of the vessel wall, I have a lot of inflammatory cells because this is a case of vasculitis, which means inflammation of the blood vessel wall. And so, in fibrinoid necrosis is seen only at the microscopic level. It is not seen as any gross in the gross. It is seen in immune reactions involving blood vessels and in cases of malignant hypertension. It's characterized by accumulation of fibrin, immunoglobulins, plasma proteins within the walls of the affected vessels because this area showed damage of the media and replacement by these infiltrated proteins, and they appear as bright pink and amorphous material in H&E sections. This is the fibrinoid necrosis. We don't have much to say about fibrinoid necrosis. Fat necrosis is the other type of necrosis with F. I said we have two types of necrosis starting with F, fibrinoid and fat. Fat necrosis, from its name, you can just suggest that it occurs in fat. Very good. It occurs in areas in which we have fat. So fat necrosis occurs in areas of fat that is may be mediated by enzymes and may be mediated by trauma to the fat. So the fat necrosis can occur in fatty areas in which we have fat due to trauma or trauma to the fat cells or digestion of the fat cells by enzymes. Okay, what is the enzyme responsible for digestion of the fat? In pancreas, we have what? We have pancreatic lipase enzyme. So you have pancreatic lipase enzyme, okay, and this pancreatic lipase enzyme is important in metabolism. Why? Because it is secreted by the pancreatic acini. It goes through the pancreatic duct, and then it goes to second part of duodenum, okay, after combination with the common bile duct, and this will go and pour the pancreatic lipase in the second part of duodenum to help in the metabolism of fat eaten in the food. Okay, this is the normal sequence. Fine. Of course, you have intact acini and intact ducts because lipase enzyme goes from the acini through the ducts through the duodenum. In cases of damage of the acini, in case of acute pancreatitis, itis means inflammation, so I have damage of these acini. With the damage of the acini, I have what? I have damage of the acini and ducts, and then I have release of lipase outside the normal pathway. And this lipase will go outside the acini to find fat inside the pancreas and around the pancreas, okay? And around the pancreas here, in the omentum, in the mesentery, and so on. And so this lipase will go and digest the fat cells outside the acini, inside the pancreas and outside the pancreas. The areas of digested fat, it will go and damage the fat cells. It will damage the fat cells, and these damaged fat cells will undergo what is called fat necrosis. So enzymatic fat necrosis occurs in cases of acute pancreatitis due to release of pancreatic lipase outside the pancreatic acini. These pancreatic enzymes, including lipases, will act on the fat present in the fat cells outside the pancreas, and this fat will be digested to free fatty acids. So it will act on the fat cells, and the fat cells will be destroyed, and the fat will be released and transformed into free fatty acids. These free fatty acids will find in the extracellular matrix a lot of calcium. You remember, free fatty acids will combine with calcium, leading to formation of calcium soaps, and calcium soaps will appear as white, yellow, chalky material زي الطباشير. So the areas of fat necrosis present in the mesentery or in the omentum or inside the pancreas will transform to chalky white areas due to formation of calcium soaps, and these calcium soaps are formed due to the combination of free fatty acids with calcium present in the extracellular matrix. This is the enzymatic fat necrosis. The other form of fat necrosis is due to trauma to the fat cells. And trauma to the fat cells occur when there is blunt or sharp trauma to areas of fat. You have trauma to the breast, for example, sharp or blunt trauma, maybe blunt trauma by even in a car accident, or just a trauma to the breast, or you have put a scalpel, or you just use here a blade, okay, and this blade is used during surgery. So you can have a surgery in the breast, and you just take the blade and just damage or cause trauma to the fat cells present in the breast or in the abdomen or any fatty area, or you may have a blunt trauma. Of course, this will lead to what? This trauma to the subcutaneous tissue of female breast or any fatty tissue in the body will lead to formation of a hard mass. Why hard mass? Because when you just go and damage fat cells, there will be a release of free fat forming free fatty acids, and they will combine with calcium, leading to calcification and formation of this hard mass. لما يحصل calcification الماس في البريست هتبقى hard. طبعا hard mass in the breast is an alarming sign. So hard mass in breast is an alarming sign because any breast lump is considered malignant until proved otherwise. So any breast lump is considered malignant until proved otherwise. So it may be mistaken for malignant lump in the breast. Fine. So in fat necrosis, I have enzymatic fat necrosis and traumatic fat necrosis. Enzymatic fat necrosis occurs in cases of acute pancreatitis with release of pancreatic lipase that acts on the fat present in the omentum, in the mesentery, in the pancreas itself, and this will lead to damage of the fat cells, liberation of fat, transformation into free fatty acids that will bind with calcium present in the extracellular matrix, forming calcium soaps that appear as white, yellow, chalky material. Traumatic fat necrosis occurs due to blunt or sharp trauma of the subcutaneous tissue of female breast or of abdomen or of the legs, any part, any subcutaneous tissue can be affected by traumatic fat necrosis. The importance in the breast is that it forms a hard mass in the breast due to calcification, following fat necrosis, and this hard mass is usually clinically considered malignant until proved otherwise. So this is the importance of fat necrosis occurring in the breast. If you look at the gross picture here we have a mesentery, and this mesentery shows these foci of fat necrosis that appear yellowish white, and then they appear calcified later on, appear like calcification. Here you have a mass in the breast that is present due to trauma of the breast, leading to formation of a hard calcified mass of traumatic fat necrosis of the breast. So this is fat necrosis of the breast. This is the microscopic picture of fat necrosis. Here we have, these are the fat cells, and here we have these necrotic fat cells will form large fat cysts like that. These are infiltrated or surrounded by inflammatory cells. These inflammatory cells may be acute and chronic inflammatory cells. We have neutrophils, we have lymphocytes, and we have these giant cells. We have a lot of histiocytes. This is a histiocyte, and we have giant cell. Giant cell has multiple nuclei. So this is a giant cell. We have histiocyte and we have neutrophil like that, okay, and we have lymphocytes. These are the inflammatory cells that are seen infiltrating the area of fat necrosis. So necrotic fat cells are surrounded by inflammatory reaction, foamy macrophages, and giant cells, and we may find after a while calcification that appear as these blue deposits. So these blue deposits are actually calcification seen after calcification of the areas of fat necrosis. يبقى هيبانوا في صورة blue deposits in H&E stained sections. فاحنا كده أخذنا أنواع necrosis. What are the types of necrosis? We have coagulative type of necrosis occurring in ischemic necrosis or infarctions of all solid organs except the brain. We have liquefactive type of necrosis occurring in brain infarction, pyogenic abscess, amoebic liver abscess. We have caseous necrosis occurring in tuberculous foci due to tuberculous infection. Number 4 and 5 in F, we have fibrinoid necrosis occurring in vessel wall due to immune reaction or malignant hypertension. And the last F is the fat necrosis due to enzymes or due to trauma. Okay. After that, we take the consequences of necrosis. If necrosis is followed by infection with putrefactive microorganism, I develop what is called gangrene. Gangrene اللي هي الغرغرينة. Some textbooks consider gangrene as the 6th type of necrosis, so they call it gangrenous necrosis. Others describe gangrene as a separate entity. It means necrosis followed by putrefaction. So if we choose which of the following statements best describes gangrene: infection without necrosis, necrosis without infection, or necrosis with infection? Of course, it is necrosis with infection. Gangrenous necrosis or gangrene. It is a massive necrosis with superadded putrefaction. So it is a massive necrosis with superadded putrefaction. So gangrene is a massive necrosis with superadded putrefaction. It refers to ischemic coagulative necrosis, later modified by liquefactive action of enzymes derived from bacteria and leukocytes. معناه ايه الكلام ده؟ معناه ان الاول بيحصل عندي ischemic coagulative necrosis، يبقى ischemia followed by coagulative necrosis of the leg for example، تمام؟ وبعد الاسكيميا والcoagulative necrosis اللي بيحصل ده بيجي الانفكشن عن طريق مثلا abrasion او اي حاجه، فيحصل ان الاورجانيزم بيخش على الاريا النكروتيك ويبتدي يشتغل عليها ويبتدي يفرز انزيمز ويحصل انفلاميشن جامد، فالبكتيريا والليكوسايت الاثنين مع بعض يبتدوا يطلعوا انزيمز تبتدي تدوب النكروتيك اريا، فيبتدي يبقى عندي coagulative necrosis يتحول الى liquefactive necrosis بعد شويه. وكمان النكروتيك تيشو بيبقى putrefied by the action of putrefacive saprophytic organisms on dead protein. خلي بالنا ان السابروفيتيك organisms دول موجودين حوالينا، موجودين على جلدنا، هم organisms ضعيفة ما بتقدرش تهاجم النورمال تيشو او الهيلثي تيشو، يقدروا بس يشتغلوا على الديد تيشو. وبالتالي لما بيبقى عندهم فرصة يدخلوا على الديد تيشو من خلال ووند، سكين ووند، جرح في الجلد او كده، يقدروا يدخلوا ويبتدوا يشتغلوا على النكروتيك تيشو ويعملوا له التعفن. يبقى انا بيبتدي يحصل عندي البوتريفاكشن اللي هو اسمه التعفن. So the necrotic tissue is putrefied by the action of putrefactive saprophytic organisms on that protein. These organisms may present normally in the skin or in systems with external exits زي ال GIT و respiratory system، يعني خش من ال upper respiratory أو من ال lower من ال GIT. Any system with external exit ممكن يدي فرصة للأورجانيزمز دي تخش. الجانجرينس area is black in color. دايما التعفن يبقى معاه لون اسود. ايه اللون الاسود ده؟ This is the black color due to the action of hydrogen disulfide by bacteria on iron from hemolyzed RBCs forming black iron sulfide. يبقى البلاك iron sulfide هو المسؤول عن اللون الاسود. This is the black iron sulfide is responsible for the black color. And this black iron sulfide develops due to the action of hydrogen disulfide coming from the bacteria on iron coming from the hemolyzed RBCs in the area of necrosis. The types of gangrene. We may have very low amount of water inside the gangrenous part, or we have a lot of water in the gangrenous area. If we don't have water, so it is called dry gangrene. If we have a lot of water inside the gangrenous organ, we call it wet or moist gangrene. The example for dry gangrene is the senile gangrene occurring in very old aged persons due to atherosclerosis. But the wet or moist gangrene, we have a lot of examples as bed sores, diabetic foot, and so on. Most of the gangrene that you are going to see in your clinical practice is of the moist type. The dry gangrene is rare, okay? So it is rare. This dry gangrene is rare. Most of the cases that you are going to see as gangrene will be of the wet or moist type, including bed sores اللي هي قرح الفراش، الدايبيتك فوت اللي هي القدم السكري، وحالات الايه الهرنيا اللي هي الهرنيا المزنوقه اللي هو الفتاء. لما يكون في هرنيا مزنوقه ممكن تعمل wet or moist gangrene. So these are the types of gangrene. The dry gangrene اللي هي rare occurring in senile persons is usually coagulative with very minimal bacteria because it is too dry for bacteria to grow. Liquefactive because we are going to have a lot of fluids and a lot of bacteria and a lot of liquefaction of the necrotic tissue. And so in moist gangrene it is mostly liquefactive necrosis. In dry gangrene it stops at the coagulative necrosis. Look at this picture. نشوف الصورة دي مع بعض ونبتدي نختار. We are going to choose these from these morphological features, what suits A and what suits B. First of all, which of these is black, A or B? Both. Which has dry mummified skin? Look at this one. This one is not in formalin, and this is from our museum, not in formalin. It looks like mummies. You know mummies? Mummies in the museum. So, which has dry mummified skin, this one or this one? Look at this skin. It is dry and mummified and wrinkled. So this is the dry mummified skin. Which has tense ulcerated skin? We have swelling with tense and ulceration defects like that. This is the tense ulcerated skin. This is the ulceration here, and this is the tense skin. Which is swollen? A. Which has lost toes, missing toes? A or B? Look here, we have here missing toes, and here we have missing toes. So both have missing toes. Which has line of demarcation? What's a line of demarcation? This line separates the healthy tissue from the gangrenous part. which has a prominent line of demarcation. Look at this. This is the line of demarcation, and so this one has a line of demarcation because it is a slow process. Line of demarcation needs a long time to develop. Which is the dry gangrene? Of course B. Which is the moist gangrene? Of course A. So in dry gangrene we have black, dry, mummified skin, lost toes, line of demarcation. In the wet gangrene or moist gangrene, it is black in color, it has tense ulcerated skin, swollen, lost toes, like that, and no prominent line of demarcation. This line is not very well developed. Dry gangrene, it begins in the distal part of the limb due to ischemia. So the dry gangrene is a slow ischemic process. It is a slow ischemic process. So it starts here, usually in the distal part of the limb due to ischemia, because there is poor tissue fluid and it is exposed to dryness by evaporation. So if I have the lower limb like that, it will start in the toe, which is much away from the blood vessel that shows atherosclerosis and narrowing. So this is the most ischemic part. وفي نفس الوقت بيبقى متعرض للإيفابوريشن عشان هو ماشي حافي كمان, and exposed to dryness by evaporation. And so the depth of this part of the toe is associated with evaporation, and so it will be very dry. So I have, it looks like that. It is very dry and irregular with thick wrinkled skin. Most common example is senile gangrene of the lower limb. Senile means in very old age, usually in the lower limbs. The causes of ischemic necrosis. What caused this ischemic necrosis? We have atherosclerosis اللي هو تصلب الشرايين, in which we have narrowing of the vessel by atherosclerotic patches like that طالعة من الوول. We have atherosclerotic patches that compromise the blood flow here. We may have thromboangiitis obliterans or Berger's disease, and you are going to study this in cardiovascular system, in which we have thrombosis and we have narrowing of the wall, thromboangiitis obliterans. Raynaud's disease, we have vasoconstriction of the vessels due to exposure to cold, leading to marked compromise of the blood flow. So these are the causes of ischemic necrosis. And lastly, trauma, and this trauma can lead to fibrosis of the vessel wall and narrowing. Evolution of dry gangrene. If you look at the diagram here, you have here is the vessel. Okay, here is the vessel, and this vessel shows here obstruction, and so you have ischemia of this distal part. This distal part becomes, due to ischemia, it becomes cold and pale. After being cold and pale, it starts to be black in color. It starts to die and becomes black in color, and it becomes surrounded by a zone of hyperemia due to inflammation surrounding the zone of necrosis. Then the zone of necrosis expands by increasing the ischemia, so it expands up like that, it expands, and again it is surrounded by the zone of hyperemia or congestion, which is pink in color. Again, look here, there is more expansion of the necrotic area and becomes mummified and dry until you have here line of granulation tissue called granulation tissue. This is the line of congestion, becomes filled with blood vessels, newly formed blood vessels, and it appears pink like that. This, if ischemia is continued, so the gangrenous part will go up until it reaches a good area of good blood supply. Then the ischemia stops here, the gangrene stops here, and this area of granulation tissue is called the line of demarcation. This area of granulation tissue will transform into fibrous tissue, and this fibrous tissue will be here like that. Okay, it will contract, and so it will leave this gangrenous part to fall away by itself. So we have falling of the gangrenous part at this line. This line was called line of demarcation, and here it will transform into line of separation. So the line of demarcation will change to be line of separation. If you leave the gangrenous part, it will go by itself. But if you do an operation, you usually go and amputate the limb above the line of demarcation like that. So you have a piece of tissue that is not gangrenous in cases of surgical amputation. So the evolution of dry gangrene starts in the farthest toe from blood supply, spread upwards until the point of good blood supply adequate to keep the tissues viable. So it spreads up until you have good blood supply to keep the tissues viable. There is a zone of acute inflammation called line of demarcation between the two parts, the gangrenous part and the healthy part. That is pink in color, which is pink in color here. This zone of acute inflammation transforms into what's called inflammatory granulation tissue, and you are going to take this in inflammation, and this is followed by fibrosis occurring at the line of demarcation. So it will be transformed into a line of separation in which the gangrenous part is separated, falls off from the healthy part. The gangrenous part separates and falls off. This process is very slow, and there is minimal putrefaction because you don't have enough fluids to make bacteria proliferate, and so the bacteria is minimal and there is minimal putrefaction. You have just this black, dry, mummified skin with minimal putrefaction. You don't have a bad odor, you don't have toxemia in the patient. He is just going to move like that with the separated gangrenous part, and he doesn't feel this part, and so on. Fine. So this kind of gangrene doesn't kill the patient. The moist gangrene or wet gangrene is different. It occurs in parts in which there is excess fluids and not exposed to dryness, as hidden parts or hidden organs. The process of proliferation of organism and putrefaction is very rapid. It is not slow like dry gangrene because of excess fluids, and so these excess fluids give the bacteria the opportunity to proliferate quickly, and so there will be putrefaction, secretion of toxins from the bacteria, leading to severe toxemia in the patient and rapid process of gangrene. Wet gangrene occurs rapidly due to blockage of venous blood flow. So it starts by blockage of venous blood flow. So if we have an artery going inside an organ, and we have a vein coming outside the organ, what do we have? We have blockage of the vein by thrombus or something like that. If the vein is blocked, so the blood goes from the artery into the organ, should go to the vein, but this will stop, and so the blood will accumulate here in the organ, and the organ becomes swollen. So it starts by blockage of a vein. This will lead to swelling of the organ by that, and this will lead to what? This will lead to increased pressure inside the organ, and so the arterial blood supply will find a lot of pressure in front of it, and this will eventually lead to diminished arterial blood flow. So there will be backward pressure on the artery, leading to diminished arterial blood supply. So it starts by venous obstruction, leading to severe congestion in the organ, okay, and accumulation of the venous blood. This will lead to swelling of the organ, accumulation of unwanted venous blood, and this will prevent the good arterial blood that is full of oxygen to go through the organ. This will lead to ischemia of the organ. So it starts by venous obstruction and ending in arterial obstruction. The affected part is stuffed with venous blood, which helps rapid growth of putrefactive bacteria, especially with high sugar content, especially in diabetic patients, in diabetes mellitus. So I have a lot of fluids here that will help any bacteria to go and proliferate. Bacteria usually come from wounds, abrasions, or wounds to the site of gangrene. Toxic products of bacteria will be absorbed, leading to severe toxemia. So I have a lot of bacteria proliferating here, and these bacteria will produce a lot of toxins. These toxins will go into the blood, leading to severe toxemia in the patient. Rapid spread of the gangrene will occur with no obvious line of demarcation because the process is rapid. So if I have the leg like that, I can have gangrene in the toe today. Tomorrow I can have half of the foot, and the third day I can have all the foot. So this is a rapid process, and I don't have a line of demarcation that is granulation tissue and inflammation. This is not present in this case because it needs a slow process to occur, and this process here is very rapid, and so there is no time to form a line of demarcation. Organs affected by moist gangrene. We have moist tissues and organs as lung, mouth, external genitalia. They have access to the external environment. They can develop gangrene due to presence of moisture, excessive moisture, so they develop moist gangrene. Intestine, as in cases of strangulated hernia. يعني ايه strangulated hernia؟ اللي هو الفتاء. فتاء يعني ايه؟ يعني passage of the intestine. Okay, the intestine inside the abdominal cavity with its mesentery, they are free to move with increased intra-abdominal pressure, as in cases of straining, constipation, labor work. This will lead to straining and increased intra-abdominal pressure, so the intestine can pass through the hernia ring together with its mesentery. Okay, this is called hernia, and so the intestine passing through this ring will be constructed, will be strangulated by the ring, and this strangulation will lead to what? This strangulation will lead to pressure on the blood supply present in the mesenteric vessels in the mesentery coming outside from with the intestine. Okay, this will lead to obstruction of the vein easily, then followed by congestion. Intestine becomes swollen, okay, inside the sac, and this will be followed by arterial obstruction, necrosis, and with this necrosis I have a lot of microorganisms inside the lumen of the intestine, leading to gangrene. So I'm going to develop wet moist gangrene in case of what? Diabetic patients are of course it's true. Why? They develop what is called diabetic foot due to the presence of atherosclerosis that increases with diabetes mellitus. High sugar content present in the legs, peripheral neuropathy. You have anesthesia, you have loss of sensation. Okay, and with loss of sensation you can have trauma, and this trauma can lead to access of the microorganism by abrasions or wounds through the area of ischemia and necrosis. So the patients with diabetes mellitus, especially uncontrolled diabetes, are at high risk of developing moist gangrene of the lower limbs. Severe crush injuries, as in case of car accidents, can lead to moist gangrene also. Skin, last organ to be affected by moist gangrene in cases of bed sores. Bed sores are اللي هم قرح الفراش occurring in قرح الفراش. Bed sores occur in bedridden patients at pressure sites. This is the photo showing strangulated hernia here, and this is the ring, and this is the loop present in the hernia, and this for example inguinal opening, and this is the swollen intestine with starting gangrene due to cut of blood supply following congestion. Bed sores هما قرح الفراش. This occurs at pressure sites in bedridden patients. If patients are they don't move, there is always pressure exerted by the bone and the bed, and in between I have this soft tissue and skin here that is present in between the bone and and the bed. These areas where we have extensive continuous pressure will have ischemia and will have congestion, because we have obstruction of the venous blood flow, because the veins are superficial and so they are obstructed at first, followed by congestion, followed by arterial obstruction leading to necrosis, and of course I have a lot of microorganisms on the skin, so I'm going to have gangrene. Look at this. This is a bed sore showing here gangrene. This is black tissue, gangrenous black tissue inside the bed sore, and maybe it can be very deep, reaching to the bone. So it can be very deep, reaching the bone. It can occur at pressure sites. These are the bed sores, and there are examples of moist or wet gangrene. Let's match these pictures and tell me A, B, C, D. Which is dry gangrene and which is wet gangrene? All have gangrene, but which is dry and which is wet? Starting with A. Wet or dry? Of course, it's wet because we have swollen limb here and we have starting gangrene here in the toe in a swollen limb. Fine? Okay, look at this. Look in B. B is intestine. And look at this intestine. We have what? We have here black gangrenous intestinal tissue. This moist gangrene usually due to many causes, including inguinal hernia. Look at C. In C, what do we have here? We have gangrene of the toes. We have mummification, and you have a prominent line of demarcation. So this is a dry type of gangrene. Fine. So this is dry type of gangrene. Look at D. Okay. Which is the gangrenous? This one is the gangrenous. Is it wet or dry? Of course it's wet. Why is it wet? Because it's swollen like that, and there is no, look, the line of demarcation is very identified line of demarcation. Here you don't have a specific line of demarcation. It is something irregular with no granulation tissue or fibrosis like this one. So this is wet gangrene, this is wet gangrene, this is wet gangrene, and this is dry gangrene. Lastly, one type of wet gangrene that is a very bad special form of wet gangrene is called gas gangrene. And with gas, you mean there is production of gas inside the wet gangrene. You have a lot of bubbles. The organisms responsible for gas gangrene are gas-forming gram-positive exotoxic anaerobic bacteria such as Clostridium welchii and Clostridium septicum. So these are the gas-forming gram-positive exotoxic anaerobic microorganisms. The causes of gas gangrene are usually very serious, as open contaminated wounds during wars. This occurs usually during wars or severe car accidents. Complication of colonic surgery in some cases. What happens in gas gangrene? Look at this. Here you have the limb showing moist gangrene, and you start to have pupils here. Look at the pupils. These are the pupils present under the skin. So the limb is swollen, it is edematous, and it is crepitant due to presence of gas bubbles. Of course, it is painful. Then the affected tissues become soft, friable, blue-black with a very bad odor due to hydrogen sulfide deposition. So this is the swollen edematous crepitant painful limb, followed by being soft, friable, blue-black with bad odor due to hydrogen sulfide. Of course, wet gangrene in general and gas gangrene in particular is a very serious condition, because the general condition is very bad due to severe toxemia, and death occurs due to circulatory failure and septic shock. So this is the case with moist gangrene and the worst type of moist gangrene, which is the gas gangrene. In summary, the types of necrosis include coagulative, liquefactive, caseous necrosis, fat necrosis, fibrinoid necrosis, and gangrene. Gangrene may be dry or may be moist. In dry gangrene, the process is slow and the putrefaction is minimal. In the moist gangrene, the spread is rapid and the putrefaction is maximal, so you have a very bad odor and toxemia. The organs in dry gangrene are of low tissue fluid. They look dry, mummified, black with slight offensive odor, while in moist gangrene they have excess tissue fluid, swollen, edematous, ulcerated, offensive odor. The line of demarcation is present in dry gangrene only. Patients have bad general condition in case of moist gangrene with severe toxemia, and usually the patient dies of circulatory shock, while in dry gangrene the general condition is not bad with minimal toxemia and the prognosis is not bad. Let's solve this match question before we go. Traumatic fat necrosis, caseous necrosis, fibrinoid necrosis, and gangrene. Traumatic fat necrosis occurring in the breast, leading to formation of hard lump, may be mistaken for breast cancer. Very good. Caseous necrosis, which cheesy, partially liquefied necrotic tissue. Very good. Fibrinoid necrosis occurs in immune reactions involving blood vessels and malignant hypertension. Gangrene is a necrosis followed by putrefaction. Very good. Necrosis followed by putrefaction. An old atherosclerotic man had a minor trauma of the toes, which was followed by blackish discoloration of the big toe. Which of the following is responsible for the black color of the toe? What happened to this man? Yes, gangrene. Which is responsible for the black color? Very good. It is iron sulfide. This is responsible for gangrene. And thank you very much.